Assalamualaikum and good morning to all our viewers. Welcome to National Institute of Health NIH Continuous Medical Education Session 2022, organized and brought to you by Sektor Sumber Maklumat Penyelidikan NIH. NIH CME, the series of online medical education session or webinar which provide platform for NIH researchers to share their expertise and research findings to the public. Today's CME session is the first CME program organized for the year, and we are planning for another 5 throughout the year. We look forward for your participation in the next session as well. For those who just joined us, please do register your attendance in the link provided in the comment section below. E-certificate will be given after the show. If you have any question, comment about the topic, please type in the comment section. As for today, we'll be having a special guest from Institute for Health Management, Dr Muhammad Nur Amir bin Abdul Rasib, and he will be sharing with all of us about a recent study conducted by IHM. Before we start, let's take a look at IHM corporate video.
The healthcare industry is continually evolving, which poses new challenges in the world today. The need for health management arises with advancing technological innovations, changes in healthcare regulations, and ever-rising patient expectations. Marking its success since its humble beginning in 2000, the Institute for Health Management is part of a remarkable journey that many can attest to. We are committed to being a research and training hub, as well as providing invaluable consultancies to fulfill health management needs in delivering and managing quality healthcare in Malaysia. Throughout the years, our evidence-based health management researchers strengthen decision-making and facilitate vital policy formulation and implementation throughout the Ministry of Health. Since 2006, we have conducted over 650 courses and have empowered over 30,000 individuals. Our goal is to guide you to grow into your full potential and to maximize your performance. We impart the relevant knowledge, technical skills, and organizational mindset to healthcare managers through consultancies, leading the way to achieve a transformed healthcare system. We are comprised of 3 centers, which are the Center for Leadership and Professional Development, the Center for Organizational Excellence Development, and the Center for Clinical Governance Development. Our talent grooming program, TGP, enriches the process of building leadership capability and inculcate other qualities among potential technical healthcare professionals. We take pride in producing innovation by developing TGP and MyTGP, which officially became intellectual properties of the Ministry of Health. Our initiatives in research in optimizing hospital services and issues of overcrowding led to the innovation of Cluster Hospital. Cluster Hospital is a concept where all nearby government hospitals share and expand their medical resources, services, and expertise. We have been involved in the training, implementation, and evaluation of cluster hospital initiatives since 2012. Lean thinking is about eliminating waste in work processes and optimizing available resources. It was introduced as part of the government's effort to improve efficiency and tackle issues of overcrowding in public hospitals. IHM is the Lean Center of Excellence for research, training, and consultancy in the Ministry of Health. We take pride in our involvement in high-impact health management research. The housemanship training and its associated research projects set off a ripple effect where it has been translated into policy and implemented into the Malaysian healthcare system. Over the years, we have fostered partnerships with numerous local and international agencies. Our mutual aim is to promote and support excellence in healthcare by building collaborations. We grow in strength, aligned with a vision of striving towards the center of excellence in health management. The Institute for Health Management, or IHM. Better solution through research.
Hi, Dr. Amir. How are you today?
Thank you for having me.
Okay. Now, welcome to the NIHME session. Introduce us a little bit about yourself, your team member, as well as the study.
Bismillahirrahmanirrahim. Assalamualaikum and good morning. I'm Dr. Amir, a medical officer from Institute for Health Management. Right, okay. Institute for Health Management, or IHM, one out of the six institutes under the National Institute of Health, or NIH, with core business of research consultancy. So IHM, among others, focuses more on clients' experience, patient safety, health leadership, human resources for Ministry of Health, as well as the cluster hospitals and the healthcare initiative. So today we are delighted to share the finding one of our study, which is balance of burnout among the nurses in the Ministry of Health Malaysia.
Alright, so Dr. Amir, kita selalu dengar orang cakap pasal tired, burnout, or maybe fed up. So, how do you explain burnout? Does it happen to everyone?
Okay, for that, I would like to introduce our team members. The study is led by Puan Nushada, our research officer, and this is a collaboration study with Institut Kesihatan Umum, IKU, and we have 7 team members altogether. Right, okay. Burnout, burnout is a specific work-related syndrome resulting from prolonged response, chronic emotional and interpersonal stressors on the job. The WHO reported that a high number of healthcare workers had the intention to leave their job because of burnout. So, a part of possible brain drain, burnout is also associated with significant financial costs, with a recent study reporting up to 8.5 million US dollar worth of total loss. So here is a list of common causes of burnout and the subsequent effects of staff, schools, and organization. Some of the reasons that we are familiar with include long working hours, inadequate or unsafe working conditions, as well as understaffing. Okay, worldwide, the prevalence of burnout among healthcare practitioners has been extensively studied. As early as 2013, there has been a systematic review showing a 22-40% prevalence rate of burnout among nurses in 10 European countries. Locally, many studies have been done to explore this issue. Of course, for the COVID-19 pandemic that struck end of 2019. However, most of these earlier studies were single-center studies or focused mainly on doctors. So in 2018, 2019, we undertook this study. Unlike previous burnout studies that focused on prevalence, we also investigated the coping strategies among nurses in Malaysia. So our objective, generally, we wanted to determine the prevalence of burnout and types of coping strategies among nurses in Ministry of Health facilities in Malaysia. Apart from the prevalence of burnout and coping strategies, we also set out to identify the associated factors to provide recommendations for the stakeholders to reduce burnout. This was a national level cross-sectional quantitative study with multi-stage stratified random sampling throughout the public hospitals and PKDs in Malaysia. Data collection was conducted between July and November 2019. A total of 2,516 of nurses were recruited, making it the study with the largest sample size in Malaysia on the issue of burnout. Those on leave of absence with underlying psychiatric illness were excluded. Staff in special institutions such as Institut Perubatan Respiratory and Pusat Darah Negara were also excluded due to the slightly different nature of work compared to the remaining study population. So our sampling method was constructed with the input of statisticians from the National Health Mobility Survey, or the NHMS, by IKU. It closely resembles the NHMS method of recruiting nationally representative sample populations for their annual survey. In this study, to obtain a national representative sample, the country was divided into 6 zones, namely North, Central, South, East Coast, as well as Sabah and Sarawak. One state was randomly chosen to represent each zone. Complex sampling was applied to obtain a nationally representative study population of nurses. The total sample size was divided proportionately to the 6 selected states based on the actual number of staff in each state. Generally, our proposed study framework is as shown in this figure. Socio-demographic and professional characteristics play a role in the development of burnout, either as a risk factor or a protective factor. Individuals may react to their stressors by adopting certain coping strategies. The relationship between stressors, coping strategies, and burnout is of interest for us in this study. So, Brief Cope is a shortened version of the Cope inventory to measure the coping strategies used in a particular stressful encounter. It encompasses thoughts and actions that people use to deal with internal or external demands of a specific stressful event. There are 2 items under each of the 14 subscales that assess the 3 categories of coping strategies, which is the emotional focus, problem focus, as well as the dysfunctional coping. So coping strategies are important mechanism to mitigate adverse effects of high stress environment, and it has personal and organizational implications. For instance, positive use of coping strategy can prevent the development of burnout. Right, there are many ways to define and measure burnout. The Maaslach Burnout Inventory is a reliable and validated instrument that has been used widely in clinical and educational settings. The instrument defines 3 components of burnout: emotional exhaustion, depersonalization, and a reduced sense of personal accomplishment. So emotional exhaustion occurs when workers feel great negativity of themselves psychologically. Depersonalization occurs when workers have negative and cynical attitudes towards their clients. And personal accomplishment occurs when workers evaluate themselves positively, particularly in relation to their work with their clients. So according to the previous research, high scores on emotional exhaustion and or depersonalization, but not a low score in personal accomplishment scale, can distinguish the clinical burnout from the non-burnout.
Thank you. Nampaknya banyak perkara yang kita boleh kaitkan dengan burnout ni kan. So maybe you can share with us ataupun terutamanya dengan penonton-penonton kita kat luar sana, dapatan utama atau your main findings of your research.
Right. Okay, thank you. So generally, there is no significant difference in the baseline characteristics of respondents in the hospital and primary care settings. The majority of them were female and married with 1 to 3 children. A big proportion of nurses is between 31 to 40 years old. Approximately half of them were from the M40 income level, And it is worth pointing out that majority of our staff only manage 6 to 7 hours of sleep, some with less than 6 hours. So in terms of professional characteristics, some variation is noted between the grades and years of service. There are more U29 nurses in the hospital setting compared to U19, U24 nurses in the primary care. Majority of our respondents have served in KKM for more than 10 years, despite the fact that most of them were in U29 grade or lesser. Approximately 1 in 3 of hospital nurses and 1 in 5 primary care nurses encountered traumatic events at work before, and only 1/4 of them ever received debriefing. Our results also showed a small percentage of staff involved in part-time work. This is to show the working schedule whereby 71% of nurses in the hospitals are involved in shift work. Apart from that, we also obtained info on work travel. The majority of nurses and staff stayed within 15 minutes and 10 kilometers from the workplace. The next two variables look at the amount of time our staff spend at work out of the supposedly protected family time during weekend or after office hours. So in all 4 categories, more than half of them spent more than 5 days of public holiday in the past month at work. Similarly, the majority were doing on-calls or extended hours more than 4 times. So the next 2 slides are a list of workplace conflicts with colleagues, superiors, patients, and personnel. The items included were retrieved from various literature. We would like to highlight the common conflicts experienced by our staff in their workplace because they can be a source of burnout. So high proportion of role conflict with other profession and some profession for hospital nurses. Comparatively, there is a higher level of work conflict with superiors, especially in terms of pressure of deadlines. Hospital nurses have a high level of fear towards occupational hazard and encounters with demanding patients or family members. And finally, a higher proportion of hospital nurses experience lack of incentives and felt underpaid. So that was an overview of the baseline characteristics between nurses in the hospital and primary care settings. So based on a systematic review published in 2020, an overall pooled prevalence of burnout symptoms among global nurses was 11.2%. The prevalence in some other countries are shown here, ranging from more than 30% in the US and Singapore to as low as less than 4% in Turkey and Indonesia. However, do bear in mind that this is a rough comparison as the rate can differ based on the study tools, classification of burnout, and sample population. So, now based on this study, the overall prevalence of burnout among nurses was 24.4%, with a slightly higher rate among the hospital nurses. Males, younger age group, single, childless nurses recorded higher prevalence of burnout, similar with some of the studies elsewhere. The level was higher among hospital than primary care nurses. So in this slide, it is interesting to note that the burnout level is the lowest among M40 household incomes in the group. The higher level of burnout associated with less than 6 hours of sleep per day for both groups of nurses. The difference is statistically significant between hospital nurses with less than 6 hours and those with more than 7 hours of sleep daily. So primary care nurses with comorbidities were also predisposed to high levels of burnout. The higher prevalence of burnout among nurses who smoked echoed the findings of studies in China, Italy, and Saudi Arabia. So this chart shows a few important findings. First being the higher prevalence of burnout for all variables among hospital nurses. Secondly, the prevalence increased with higher education level, grades, and inversely with years of service and time spent on direct patient care. So one of the possible reasons was the lower time spent on direct patient care, nurses with high burden of administration tasks. And evidence pointed out that they are more predisposed to burnout at work. Among those who experienced trauma event at work, 40.4 and 37.1% at hospital and primary care suffered from burnout. The prevalence is higher among those who did not receive any debriefing by their superiors. The purpose of debriefing in healthcare is to initiate a discussion targeted at actions, thought processes, and to reflect on the event in order to decrease professional stress and to improve concentration, morale, and work engagement. So it is not surprising that nurses involved in part-time work had a higher level of burnout, especially among hospital nurses. As for shift work, compared to a study in Thailand that showed 1.5 times more frequent burnout among shift workers, our study showed that a difference of 5% between shift and non-shift nurses in hospital. The prevalence of burnout was similar between nurses performing less or more than 24 shifts per month. However, the level of burnout increased with the number of night shifts and double shifts. So in terms of travel to work, the lowest burnout was among those who took less than 15 minutes and less than 10 kilometers per one way. The more days they worked during weekend and public holiday, and with more on-call or extended hours duties, the higher prevalence of burnout, likely due to the lower personal and family time. This was especially obvious among hospital nurses. In terms of work conflicts, an overall pattern emerged whereby hospital nurses experiencing these conflicts had higher prevalence of burnout than their primary care counterparts. The work conflict with the higher influence on the development of burnout for hospital nurses were role ambiguity with colleagues and unclear job expectation. So while the prevalence of burnout among primary care nurses who experience work conflicts was low in general, the highest association was detected between role conflict with other nurses, role ambiguity, and pressure of deadlines. In order to reduce role ambiguity, it is important to be clear about the role definition, tasks, responsibilities, and expectations on the job. This can also reduce the occurrence of role conflicts, whether between nurses or with other professions. Okay, work conflicts arising from the care of patients are part and parcel of the job. Hospital nurses deal with more urgent and critical patients in general, thus predisposing them to more encounters with pressure of death and dying, and dealing with demanding clients. While it is inevitable to face such conflicts, nurses and other healthcare workers need to be given the appropriate training and support to deal with these issues in a positive manner. So majority of the nurses are females who are also multitasking as wives, mothers, daughters, parents in the family. Thus, work-family conflict can be a main source of burnout among them, especially hospital nurses who need to work in shifts. Now, based on the analysis, the use of religion as a coping strategy was higher among nurses without burnout compared to those without burnout. Among the dysfunctional coping strategies, the application of self-destruction, venting, behavioral disagreement, and self-blame were significantly higher among nurses who experienced burnout. Finally, we would like to show the predictors of burnout based on multiple logistic regression analysis. The first Venn diagram shows a summary on the risk factors predisposing to burnout. The figure in the bracket represents the adjusted odds ratio. As you can see here, traumatic event at workplace is a significant factor that can cause 4.6 times higher risk of burnout for hospital nurses and 3.3 times for primary care nurses. For hospital side, U29 staff nurses were 5.9 times more likely to experience burnout. Other significant risk factors for hospital nurses include involvement in part-time work, feeling underpaid, having no children or 1 to 3 children, working nights for more than 6 times per month, and workplace stressors such as work-family conflict, role conflict, and role ambiguity. The significant risk factors differ slightly from primary care nurses as shown here, with the most significant one being pressure of deadlines, followed by comorbidity, great working on weekend and public holiday, and lack of support. So the next slide shows the protective factor for burnout. Debriefing following traumatic event half the risk of burnout for hospital nurses.
Begitu serius dan membimbangkan ya, sedikit sebanyak membimbangkanlah tuan-tuan dan puan-puan. Jadi Dr. Amir, bagaimana cara untuk mengatasi masalah burnout ni? Maybe there's like some recommendation for all of us that you can share. Perhaps some exercise, new hobbies ataupun mungkin shopping ke, macam mana?
Right. Okay. We outline the recommendations based on the socio-ecological framework as shown here. Very often, studies focused on individual and organizational levels. However, the impact of interpersonal relationship or community as well as bigger societal roles are also important and untapped approach in the mitigation of burnout. Addressing burnout on an individual level will not be enough, and meaningful steps to address the crisis and its fundamental causes must be taken at systemic and institutional levels with concerted efforts from all relevant stakeholders. On the individual level, our study highlighted the important protection towards burnout with the application of positive coping strategies. Therefore, this aspect should be strengthened among the nurses and given the equal attention just as other technical skills. Here is a list of commonly recommended intervention to safeguard the well-being of healthcare workers. Healthcare service is unique in a way that teamwork and collaboration is indispensable to achieve the outcome. This is why the interpersonal relationship is so fundamental. Many results pointed out the likelihood of higher burnout with workplace conflicts. Therefore, it is important to improve communication among co-workers and superiors towards preventing role conflicts, improving team spirit and cooperation. So inter and intra-professional care coordination must be emphasized to reduce role conflicts and role ambiguity. Social support outside workplace is also vital to prevent workforce conflict. For example, community support in terms of housing nearer to workplace, 24-hour childcare service, especially for families with 2 working parents with no other family support. So intervention for burnout reduction will not be successful without organization-directed changes. Establish screening for burnout annually via feasible methods such as online survey with target groups that has comorbidities, traumatic event at workplace as they are at high risk of burnout. So engagement can be made by nursing boards with authority to re-evaluate the job scope and descriptions, standards and KPIs to overcome specific issues such as number of night shift, work on weekends, so that the appropriate staffing and work schedule can be formulated to reduce high workload. Awareness and acknowledgement among directors or heads about the detrimental impact of burnout is imperative so that support can be given to staff in need. Society-directed interventions are ones that focus on improving policy broadly. Burnout must be viewed in the lens of social phenomenon rather than mere individual struggles or organization challenges. Reframe burnout as a occupational hazard and patient safety issues to obtain the necessary resources and attention towards it. Policy changes must be pursued, exploring the issues such as underpaid, lack of recognition, and promotion. Last but not least, instill clear aims and expected challenges, even from college level, to prevent misguided expectations among nurses. So, as a conclusion, taking into account our COVID-19 pandemic, nurses represent a majority of the frontline workers in the current COVID-19 pandemic. Secondly, known and new stressors will certainly be amplified, putting the workforce at an increased level of strain. Thirdly, given the nurse workforce is predominantly female and married, the additional child rearing and domestic tasks during lockdowns will intensify their burden and risk of burnout. And finally, determining the ways to prevent, manage, and address burnout among this group of healthcare workers is of vital importance for themselves and, more importantly, for patients and society.
Thank you, Dr. Amir, for your elaborated explanation. A very interesting study with such important findings. So, since we have a little bit of time, so maybe we can open up for a Q&A session from our audience. Okay, kalau kita tengok kat sini, we already have a few questions, so I'll just pick one daripada Iskandar. How do you think the burnout level have changed in the past 2 years since you conducted the study?
Right, okay. The study was conducted in 2018, 2019, which in fact more than 2 years ago, and of course before the COVID-19 pandemic. For now, I think it is fair to say that the level of burnout might increase tremendously with additional stressors such as the scale of the COVID-19 outbreak, the novelty of the disease, the uncertainty of its progression, and of course, it's how will it all ends. This all adding up to the mental strain on top of the physical burden of our frontliners.
Okey, terima kasih Dr. Amir. Kita ada soalan yang kedua kat sini daripada Puan Nur Khairah. Would you say that part of the reason our frontliner have been performing their duties in such an excellent way during the pandemic is partly due to the fact that they have been always working under high pressure, setting and facing a high level of burnout? Macam mana tu?
Probably. We need further study. We need further study on that. But to a certain extent, our frontliners, included our nurses, might develop some extent of resilience to be able to ride through the storm. Again, we would like to emphasize that the high level of stress and burnout can be destructive. Therefore, the necessary strategies need to be put in place.
Betul-betul. Sememangnya kita kena sentiasa hargai frontliner kita kat seluar sana. Okey, jadi kalau kita ada satu lagi soalan kat sini, saya dapat daripada Dr. Sarah daripada Hospital Selayang. The findings are more on the individual level, such as training. But what are your view on different level, for example, organizational level?
An interesting question. Right. Some of the organizational factors it's hard to modify. For instance, nurses need to perform shift work due to its nature of work. But it is best if we can reduce the intensity of the workload, improve teamwork, as well as do some schedule changes. But nevertheless, the best thing we can do is equip our nurses with the right attitude.
Okay. So, terima kasih Dr. Amir. Semoga penjelasan tadi dan soalan-soalan tadi sedikit sebanyak dapat memberikan maklumat tambahan kepada penonton-penonton kita kat luar sana. Okay, thank you everyone for your attention and thank you for all the question. For more information on the study, or if you have any question, or if you want to know more about the study conducted by IHM, please refer to the contact info below. Again, for those who just joined us, a little bit of reminder, please do register your attendance in the link provided in the comment section below. E-certificate will be given after the show, and please don't forget to subscribe to our YouTube channel. All right, till we'll meet again for the next CME session, and goodbye.